Hey there, and thanks for listening to the Beyond These Clinic Walls podcast. I'm your host, Julia, a PT turned product professional, joined by my delightful partner in crime co-hosts, Emma.
This is my tribe. This is how I think.
And Emily.
That is the best getting into PT story I've ever heard.
Founders of the Clinician Transition. Each episode, we interview former rehab professionals who have leveraged their clinical skills into non-traditional roles. I invite you to come hear the journeys, follow the career paths, and learn about the opportunities beyond these clinic walls. On today's episode of Beyond These Clinic Walls, we sit down with Brandy Wilkins, PT, DPT, CPHQ. Brandy is a healthcare quality executive with a clinical background in physical therapy. She currently serves as a quality and risk director and patient safety officer in an inpatient rehabilitation hospital in the Atlanta metro region. Prior to this role, she worked in quality and compliance in a local community-based hospital system, serving the rehabilitation department at multiple campuses. Brandy has a long list of achievements in academics, including a master's of physical therapy from the Ohio State University, her clinical doctorate in physical therapy from the MGH Institute of Health Professions, and holds a credential as a certified professional in healthcare quality through the National Association for Healthcare Quality. Happy listening. Well, Brandy, welcome to our show. We're so happy to have you here.
Thank you. I'm so excited to be here. Thanks for having me.
Yeah, of course. So let's just jump right in. I want you to first give me just an overview, high level of your experience, maybe walk me through a little bit of your clinical history, and then what your current role is now and what that role is.
All right, lots of questions at once.
I know. Well, we can break them down too as we go. Yeah, give me your spiel.
All right, so background. So I am a doctorally prepared physical therapist, but I actually started out with a bachelor's of biology. I went to PT school to get my master's initially from the Ohio State University. At that time, it was only a master's. The program that I went to transitioned to a doctorate like a year after I graduated.
Oh.
But Ohio State was preparing for the doctorate, so they gave us a lot of those doctoral classes. So that helped when I actually went back for my DPT later, which was like 3 years later.
How did they decide to cut in? But how did they distinguish preparing for versus actually?
Well, they couldn't call it a doctorate yet because you have to do all the, CAPT, all that CAPT stuff and, preparing for it. Mm-hmm. But some of the doctoral level stuff was diagnostics and, research and all of that stuff. So they were doing that with us and giving us those classes, even though they couldn't call it a doctorate. So when we graduated with the master's, they told us, we'll probably be ready for the doctorate in a year. But by that time, I had moved states. I wasn't going back to Ohio. So I was like, well, it is what it is at this point. But my first job out of school was acute care, hospital, and outpatient. And I did some PRN and long-term acute care and SNF. And so that gave me a lot of experience. I wanted to be a generalist. I think I've always wanted to be a generalist as a PT. And so I tried to dabble in a lot of different things. I think the only thing I didn't do was peds and home health. Mm-hmm. And so a few years in, I went back to get my doctorate while working, 2-3 jobs. Because at that point, you're like, I don't want more loans.
Yeah. How was that transition? How did you balance all of that, going back to school plus multiple jobs?
Yeah, so I was single, so it's much easier. No responsibilities, nobody. So I would work, 8 to 5 or whatever that was during the day, and the DPT was online through MGH, Mass General. And because Ohio State had given me a lot of classes, I didn't have to retake classes. So I was able to exempt some classes. So I took 1 or 2 classes at a time online, and it took me, I think, 2 semesters. So it wasn't that bad. I mean, I say it wasn't that bad. It was still a lot of work, but I didn't have to go on campus. So I would, on the days I didn't have classes, I would do PRN. I mean, so essentially to pay for it. I mean, it was The, the course I went to was so expensive. It was like $900 a credit hour or $700 a credit hour. I mean, that's like crazy. And so, I didn't want to loan that out or do that as a loan. So I just had to make a decision to work, but I didn't have anybody relying on me. So I was just working all the time.
How did you feel, not just balancing it, but having the experience, but then going into classes? I'm sure there was some overlap with that too. Did you feel like you were really learning a lot of new things, or were you reinforcing the skills that you learned actively in the clinic at the same time?
I think both, because I was able to see real time, not just theory of how this stuff is working, right? And kind of put it into practice at the same time. And so that was definitely helpful, made it a lot easier to pass the class because you kind of understood how it all works together. And then when you had to do projects, you had real life patients or real life situations to draw from, which I thought was a lot more beneficial than if I had went straight on through and went back to get my doctorate at the beginning. So I finished that like 2007. So still working multiple jobs. And then 2008, I decided to travel. I said, okay, I'm going to try traveling. And I did that for 4 years and loved it. Lots of great experiences as a traveler. I mean, they throw you in there, but it is some good experiences. I did that for 4 years and then ended up in the Atlanta metro and then stopped traveling and started down this kind of non-clinical, non-traditional type journey. And that's a brief overview.
So at what point did you start transitioning from staff therapist to some of those different roles? So I think your program coordinator was kind of that first leap.
Yeah. So interestingly enough, I had applied for a supervisor position before I got the program coordinator position that I didn't get. And so, of course, you kind of are a little heartbroken at first. Oh my gosh, why didn't they pick me? And all this stuff. So I started reevaluating what I wanted to do with my clinical degree, because at that time, all I really knew was I could specialize, which I didn't really want to do because I wanted to be a generalist, or I could do academia, which at that time I didn't really want to do, or you can go the supervisor manager route. But I find that in the PT world, there's a lot of ceilings with that because people in those roles don't really leave those roles. In my experience. So I started to reevaluate what I wanted to do, and I came across the quality risk track, talking to friends and researching, looking into things. And I said, oh, this might be interesting. I started looking more into it. And then the program coordinator position came open at the hospital where I was working, and it was a created position at the time. So they were newly defining it. And so when I applied for that, I received that position. And I was able to help define it, the KPIs and what does this look like, and set the precedent for what that role would do, which I thought was cool. At the same time, I started working with the quality improvement organization. So I was kind of getting both experiences at the same time and really fell in love with it.
I want to rewind a little bit. So the program coordinator role, it was quality and what was the
It was
realm?
Quality and compliance, but really what I was doing was I was working in the rehab department. I was working across multiple campuses within a hospital system to help standardize our processes so that when a patient received rehab, they could expect the same thing across campuses. So trying to help streamline our processes, make sure we were doing things similarly, and making sure we were staying in compliance with all of the different regulations, whether it was, the Joint Commission or CMS or, the APTA. But with that role, I also was the site coordinator for clinical education. So I got some experience with managing that program, did a lot of data. So how are we trending across campuses? Where are our opportunities? How do we show the value of what we do other than just productivity, right? So lots of experience from that. So it was kind of a compilation role, and it was called program coordinator, but you don't really know what that role does by that title, right?
Yeah, I was just curious when you say like standardized processes, if you could get even like more detailed how specifically clinicians are treating, or more of like the clinic flow of like how a patient gets into the clinic and gets into therapist, or like documentation processes.
So yes, all of the above.
All of it.
So each hospital campus has its own culture, own way of doing things. And so, yes, it was workflow, how the patient gets in, how does the patient perceive the care provided, how are we evaluating the therapist? Are we evaluating them the same? Because you can have one therapist go to a different campus and say, oh, you all do things so much differently. They're stricter on this at this campus, or they let us do that at this campus. All of that in documentation. Are we documenting consistently? Being evaluated on our documentation the same? Do we have the same requirements? So all of that.
Was it one day you're patient facing and the next day you're not? Or was there ever some overlap where you were doing kind of both and you eased into fully non-traditional?
So when I first accepted that program coordinator role, it was a transition, partially because they had to backfill my position, so they needed me to still do patient care. So it wasn't just one day I'm treating and the next day I'm not. But I'm gradually moved away from bedside care, and at that time I was still doing some PRN on the side, and then over time let the PRN go. It was a couple years before I actually stopped doing patient care. I don't know that. At that time, I technically 100% stopped, because if someone needed extra pair of hands, then, you're going to go and be that extra set of hands for them. And once you're a therapist, you always think like a therapist. And I was also doing some work with some of the schools, so some of like the pro bono clinic. And so I would get some patient care stuff with that. But now it's, 100% non-clinical. The role I have now is still patient facing, but it's not from see the patient, document how much did they walk, what was their gait pattern, how well did they do that movement, was there trendellum, all of that stuff is not really, doesn't really come into play as much now. But you can never turn it off 100%, I think.
That's fair. I'm glad you clarified, because sometimes we run into people who just overnight want to go from 0 to 100, and that's not typically, it can be, at least in my personal experience, and I know a lot of other people, there was some kind of tapering off in between.
Yeah, absolutely. And I find that when people decide they just get to the end and they're at their breaking point, they're at their burnout, and they just want to make that switch, but then they've never taken that step to do some of the other stuff, then it makes it harder for them to transition, because they have nothing else to pull from.
So tell us about that other stuff. What do you mean?
Like being a clinical instructor, or just raising your hand for a project in general. Your supervisor says, hey, I need somebody to volunteer to help me with this. And everybody's looking around. Are you going to pay me more to do this? Are you going to, I just want to do my job and go home. And then they make this switch in their mind. I don't want to do this anymore. And they don't have anything to pull from except from their patient-facing side. So then it makes it a little more challenging.
In your experience, Brandy, moving from that staff role to that program coordinator, you definitely had experience everywhere as you're gaining that generalist experience. But was there some projects that you stepped in on that you felt like you were really able to highlight to put you in a good position to get that program coordinator role?
Absolutely. So I was a clinical instructor and a preceptor. So when new hires came on, I would help onboard the new hires and do chart audits, chart reviews related to that. I was a part of an orthopedic pain management group where we was trying to figure out how to manage. This was back when ortho was in the hospital for 2-3 days, right? That's been a while ago. But to say, okay, well, I'll help to try to problem solve and figure this out. And, it's all about how you word it, right? Project manager, manage people, which could have just been a clinical instructor, but I did manage them. I did manage their schedules. I managed their evaluations. I managed my time and their time. And what else did I do? Oh, EMR, the medical record. So being a super user. I think a lot of people do those things or want to do those things, not realize that that's going to be such a benefit later.
feel like that's been our theme of our interviews are these side projects and then like stepping in to take on more responsibility to show and demonstrate your eagerness. Our last guest, Brad, also talked about it and how he was able to find a few places where he could implement automation to make it more successful for the clinic. So I'm liking this theme.
Yes.
I think that's a really good takeaway.
He was taking out a nail and hammer. So if you haven't listened to that,
yeah, Brad actually did like contract work for one of his things.
He literally stepped in for every extra project imaginable.
Yeah, I mean, it's all about adding value, right? Because, you know, if you can make your leader's job easier or, you know, be involved in somewhere else, then someone's going to notice, hey, Brandy's willing to step up. I bet she'd be good for this role over here.
Brandy, could you walk us through from like program coordinator to maybe the steps to what you do now and then what you do now?
Yeah. So now I am a quality and risk director at a rehab facility, which rehab is my love. Inpatient rehab is as a clinician, just being able to put your hands on patients and to facilitate movement in that way. I used to do that as a clinician back when we could keep patients forever. And, you know, you see patients coming in not able to barely move their legs and they leave walking. It's like so rewarding. I'm a quality risk director, and I went from the program coordinator role to this role. And a lot of that had to do with, I think, the experience from the program coordinator, because I highlighted my data analysis, data management skills, my ability to lead teams, my ability to facilitate change, because in the program coordinator role and in my role, you have to influence people that don't report to you. And so you have to do it from a finesse and from a collegial perspective, because they don't have to do it because they don't report to you. But yet you're responsible for the work that they do. I did a lot of networking on LinkedIn, and I found the recruiter who was hiring for this position and sent them a message and kept connecting with them. It was so cool because I hadn't used LinkedIn in that way before. And so just getting to know people, and people are more willing to help than you realize if you're willing to ask them. And so I reached out to other people in this position at other hospitals to get their feedback on what the role was like, what should I do, what should I look out for. A lot of the quality work that I was doing in my program coordinator role helped with this role, and then they could see the potential. They could see she might not check every box, but she can learn it, she can do it. And I think as women in general, we tend not to apply for positions that we don't check all the boxes for, right? And but you know, men do it all the time.
Yeah.
So I'm like, why not try? Why not try? If they say no, hey, it wasn't because I didn't try. I'm leaving nothing on the table. I took a chance on the role, and they took a chance on me, and it's worked out.
It sounds like there wasn't a course you needed to take or like letters behind your name that you needed for this. Is that correct?
That's correct. And that is actually one of the biggest questions that I get is what certifications, because I do have a certification. I have my CPHQ, which is the Certified Professional in Healthcare Quality, but I don't think I needed it to get the role. I went for the certification because those are the things I was doing already. So it's more of a validation than to get the role. I'm sure that it looks good and some roles require it. But for the most part, roles that I have seen that require that certification require it within 2 years of hire. So you don't have to have it to get the role.
I was just going to say, it definitely helps you be able to speak the language and know in interviews how to conduct exactly what buzzwords are going to stand out to the interviewer to kind of give yourself a little bit of a leg up. But on the flip side, if you do it once you are hired, a lot of companies sometimes pay for those. So it's also nice to kind of have that reimbursement too.
Yeah. And then you have it. And if you got it just to have some letters and they expect for you to know how to use it, so then you have to actually use it, in my opinion, just, to get some letters and pay some money.
Let's just back up a little bit to the importance of LinkedIn.
Mm-hmm. Yes.
Brandy, you were one of the first people I connected with when I made my LinkedIn after taking Meredith's course and learning that there's pretty much no way around having a LinkedIn. So you're kind of one of my LinkedIn famous.
I didn't even know that. Wow.
But what I think is interesting is a lot of therapists tend to use LinkedIn just when they're looking for a job and then they don't log on for months or years.
Mm-hmm.
You're always so active on LinkedIn, giving back, and you do a really good job of balancing professional and then you also pepper in some personal.
Yeah.
Thank you.
A lot of people say, oh, do I need to invest in getting a professional resume? And I know people have differing thoughts on this. However, I cannot emphasize enough. I just don't think you would have gotten this job without LinkedIn, or at least not the way it happened. I don't know if you would agree with that.
Yeah, I would agree. I think it definitely brought my resume up to the top of the stack in terms of looking at them. I don't know that it made them hire me, but at least it made them notice me, right? I mean, you're absolutely right. You have to get to know people. You have to be active. And I don't even know that I'm as active as I see a lot of people. So I think it's relative because I see people who post every day and I'm like, I don't have something to say every day. But I try to help people on LinkedIn. I try to help people understand the importance of LinkedIn. And you don't have to have LinkedIn Premium. You just need to find people who are doing what you want to do and reach out to them in a non-threatening, easy way for them to connect back to you. Because a lot of people on there are busy, but I can say that LinkedIn definitely was instrumental in this current job that I have. And it's helped me to meet lots of people. I mean, I met Meredith Caston through LinkedIn. I've met you all through LinkedIn. I've met 2 people that I currently work with on LinkedIn, kind of formed these LinkedIn friendships. And then you meet somebody, you're like, oh my gosh, how did we meet? Literally LinkedIn,
Emma, I'm so glad you brought this up because I had jotted down a note too of Brandy mentioning when she was looking at her current role, she went and researched others at different hospital systems who were in the same position and reached out to them. Can you tell us a little bit about that, Brandy? Like, how'd you go about doing that? Kind of what was your thought process? What did that format look like?
Yeah, so I literally searched quality director, quality risk at X company and see who popped up. And then I just connect, send them a note. Sometimes I didn't even send them a note. I'll just, sometimes I did send a note to say, hey, I'm looking at this role. Would you mind talking to me about it? Some of them didn't answer at all. And some were very generous with their time. I mean, you're going to get that either way, right? Some were very generous to share with me and to talk to me and that kind of thing. But I literally searched by title at company on LinkedIn until there were times when I was searching so much that LinkedIn said I reached my capacity because I wasn't a premium member. So then I'd have to wait like to the month rolled over to start again. But then people that I work, how you can look at your second and third connections, people who I was connected to, who was connected to someone else, kind of look through there too to see. And then I reached out to recruiters at, X company and tried to see, I'm looking at this position. Are you recruiting for this position? And one person said, do you know who the recruiter is for this position? And one person said, yep, it's me. So I was like, great. Well, I'm applying for this job. When are you? And so other people on LinkedIn also point you in the right direction. And then connecting you see things come up on your feed that they post that alerts you to things. And that's what I post frequently, or I posted last week, was you may be one connection away from your dream job, because it might be something that someone else posts. They might not even say anything to you at all, but they post a job that they saw, and that might be the job that you apply for and get, right?
Yeah.
So you never know. It doesn't have to be direct connection. It could just be something on your feed that seems random.
I also like that you said, well, that really resonated with me, reaching out to people in a non-threatening way.
Yes.
That was the operant word there. And I think, if people are new and, I probably made a lot of mistakes when I was new to the game too.
Definitely did, for sure, on mine.
But yes, we probably all have done it. But keeping in mind, I think it's easy to, want to connect with somebody and then get your hopes up that that person is going to get you a job at their company. But I like how you brought up that they might point you to somebody else or give you another resource, and to keep that mental framework in mind.
Yeah, absolutely. Because I don't think anyone is sitting around saying, how can I help Brandy get a job? Right?
So, I am every night, Brandy.
Yeah. And all your free time while you're eating dinner, I think this role might be great for Brandy. Exactly. And I try to be intentional about that with people who've reached out. Hey, I'm interested in this. If something comes across my feed, I'll try to tag them in if I think about it. But for the most part, people don't do that. So when you connect with somebody, it's hard to say, can you be my reference for this job, and you don't even know me? I think that can be a little intimidating for people. It can come off as sales pitchy. But I think most people are willing to answer a quick question, or, and it's also, I've read on LinkedIn too about commenting on other people's posts, because then it just gets more exposure for other people, whether it's recruiters or somebody who knows about a job, or, you just never know where that next opportunity is going to come from.
That's a good point too, is people are watching whether you know it or not. So it's important to be intentional about what you post. You made a comment about, I'm not posting all the time. I think there's a difference between talks least says most and talks most says least. And maybe try to be kind of in the middle of that.
Yeah, absolutely. Because I don't think, just in my life, it's hard to just to post something, to have nothing to say, but just from a volume perspective, I'm just going to post a post. That's just hard for me, because there's so much great content on LinkedIn. It's hard. You don't want to just repeat things, because I see that a lot too, where you someone posts something, you're like, mate, didn't I just hear that? Was it 6 months ago? It's like it came back around, like they're the one who created it, but someone else really said it, because I've heard this before, right? And so I don't want to be that person either. So I think you're right, Emma. It's a balance of, saying something that's going to add value, or something that's going to help somebody out, or, even a professional need that I have. Hey, I am hiring. If anybody knows somebody, send them to me.
Yeah, and also I follow Brandy on LinkedIn, and all our listeners should, because you post some great stuff. You do meet that balance, and it is always good stuff that you put out. So
thank you. I
every
appreciate
time
that.
I should do this. Hey there, listeners. I hope you're enjoying this episode as much as I enjoyed living it with the brilliant, beyond brilliant Brandy. If you can't get enough of her, because who can? She's great. Make sure to check out her newly launched program. It's called Defining Point Coaching and Consulting. This is Brandy's self-designed program that she created to help clinicians transition into healthcare quality. This program gives you the tools you need to succeed in healthcare quality, and focuses on things like enhancing the patient experience, improving clinical outcomes, and reducing preventable harm. If healthcare quality is a career path you're interested in, then this program is the map to help you successfully navigate it. And what better map is there to follow than someone who's gone through the steps themselves? Again, that's Defining Point Coaching and Consulting. And for your convenience, the website link is in this episode's bio. So go check it out. Okay, back to Brandy. Brandy, can you tell us, we touched on it before, but current role, quality risk management, what are you doing? What does the day-to-day look like for you?
So there isn't a typical day-to-day, but in general, no day looks the same. But in general, I'm responsible for medical staff credentialing. So making sure that our medical staff are competent to provide care to patients. Medical staff do not report to me. I'm not a physician, but helping to manage their evaluative process, make sure they have the credentials that's in place, and all that kind of stuff. Then there's
and this is all staff, not just rehab sciences.
Not rehab at all, just physicians, nurse practitioners, and physician assistants. So, because the rehab side, the nursing side, all of that is HR, human resources, right? So this is actual, do you have your license? Do you have your DEA? Do you have any medical malpractice claims that need to be evaluated? So all of that kind of stuff. And then there's the patient experience. So making sure or trying to make sure that our patients are having a good experience and are making progress, are satisfied with the care that's being provided, handling any complaints or grievances when they come up, if there's some dissatisfaction or there's a concern. So there's the patient side, and that goes with being a patient safety officer, trying to work with the clinical teams to make sure our patients are safe and that they are supported. The clinical teams are supported. If something adverse happens, it's not because someone was trying to do something wrong. So if there's processes that we can put in place to make it easier for the person that's at the bedside, knowing what it's like to be at the bedside, is valuable. So there's that side. There's the functional outcomes piece. So managing or overseeing that, overseeing HIPAA compliance and medical records, that we maintain the integrity of the medical record and we maintain our patients' privacy. We provide them with information when they request it, whether it's the patient or the physician or an attorney or, workers' comp or whatever that looks like. The quality department touches every other department. So literally we touch dietary and environmental services and facilities and nursing and therapy. And so working with those leaders to support them and to provide them with, I guess the only word I know is the support that they need to be able to do the things that they do. And, they're the ones that's patient facing. So really getting their, not just establishing something because it sounds like a good idea, but getting their buy-in and their input and, helping them with their workflows and that kind of thing.
Yeah.
And
you have an extremely broad reach. Oh my goodness.
Yeah. So it's like touches like all these different places.
Yeah.
And, that's just the overview. And then as a person, as a leader, as a therapist, because like I said, once a therapist, always a therapist, I'm a very visible leader. So I'm out there, rounding with the staff and with the patients. And if there's a call light going off, I'm running to get it too. If, there's patients sometimes that'll say, now, what do you do? You're gonna come in here and help me, go to the bathroom, or you're gonna go get me some more. Yeah, I'm in here. Your call light was on. I'm here to help you. What do you need? So
you're like, we'll do your taxes.
Yeah, exactly. Yeah, exactly. So it's all of that. It's relationships with other leaders at other companies. It's being a liaison between us and any external body like the Joint Commission or Medicare or the state, being that face, for the organization. Survey, getting us ready for survey, making sure that our staff are prepared, that we're so broad. So there's no 2 days that look alike. Of course, you have your plan and your plan falls apart. You're like, okay, this is what I'm going to get done today. And then you look up and it's 3:00 and you're like, okay, didn't do any of that. So, but I think it is very rewarding because I can influence more patients than the ones I would physically touch as a therapist. And so I can influence those who are influencing, which means I have impact on, a broader range of patients. And at the same time, the weight of the patient experience can be heavy. If something doesn't go right or someone's not happy, usually it's the quality team. If you talk to any quality director, bears the weight of that sometimes. I mean, I have dreams sometimes about random, things. I had a dream one time, this was years ago, about I was at a doctor's office and they were getting blood and they didn't check 2 patient identifiers. And I was like, you didn't check my identifiers in the dream. So, I mean, you just always are carrying the weight of this doing the right thing for the patient.
I love that even in your dreams, Brandy, you were checking all the boxes for quality and risk management.
What can I
Go ahead,
say?
Emma.
What can I say? That's how you know when you're living this stuff, when it's a part of you, when you're dreaming about it.
For sure.
My experience is in acute as well. And I always kind of thought of the people in this role as maybe the people who were RAs or resident assistants in college. Is that a fair kind of stereotype? Or who do you sometimes we'll have people where I just want to do anything I can do versus maybe something you'd be a good fit for?
What do you mean, as a quality director?
Yeah. Like if someone says I want to be Brandy when I grow up, what would maybe kind of tip you off that this kind of role may or may not be a good fit for them?
Yeah, so to the first part of your question, that this role before I got into this role was typically not at my company in particular, but in general, this role has been reserved for the registered nurse. A lot of hospitals want the registered nurse in this position, and because the biggest part of a hospital is the nursing staff, and you cannot run a hospital without the nurse. So, there's great value in that. Yeah. As rehab clinicians, we also provide great value. So we can think strategically, we can think as a team, we can think, all of those things. So we can also be good in this role. But I didn't know that until I kind of started looking into it more and kind of go into that. So if someone wants this role, you have to be able to be highly collaborative and lead by influence instead of by authority. You have to be able to look at things from a lot of different angles because there might be more than one right way. And it's not always as black and white as some of us type A therapists would want it to be, right? There's a lot of grays. Unfortunately, you can't always just say it is this way or it's not this way. And so you have to be very flexible. And the people that you're working with, the other departments, they have other priorities other than just the quality side. I mean, of course, they want to do things right. They want to do things from a quality way, but they don't always have the bandwidth to do that deep dive to figure out why is this process not working, as opposed to this process isn't working. Let's just educate everybody, right? Because sometimes it's not a knowledge issue. That's where the quality team or a quality director can come in and provide value. But, for someone who wants to do this as a therapist, I mean, it's very possible. You just have to be willing to carry the weight sometimes. You have to be willing to be patient and know that things doesn't happen overnight. You may have this great idea that you want to implement that you don't implement for 3-6 months, because everyone else has all these competing and conflicting things that are also important. So if that kind of things bother somebody, or it can be a remote position, but it's hard for people to sense your influence when they don't see you or they don't know that you can do what they do or that you understand the weight of what they're carrying too. I think that I have respect from my team because they know I'm a physical therapist. They know I will jump in there to help somebody. They know I'll be a second set of hands for them. They know that I'm not unwilling to clean somebody or wipe somebody or help take somebody to the bathroom, right?
I was going to say, as a therapist, if I was treating on the same floor and I saw you jump in at one of those call lights, I was like, oh, yep, I definitely have respect for her.
Yeah.
She knows what's up.
Yeah, because it's not just, hey, will you go in there, Julia, and go see this patient? But it's teamwork. I mean, and it really has to be.
I loved the phrase that you said, lead by influence and not authority. I feel like that could be like one of those motivational posters.
Tweetable, right?
And then I was going to ask like examples of that, but then I feel like you gave it really well. Like you are very visible and you hop in so people can see, yes, you're willing to get your roll your sleeves up. But wondering if you had any other like thoughts on that or examples.
Yeah, so I think work is being collaborative and talking to people and getting their input as opposed to telling them what to do. Recognize, and giving them the opportunity to make a recommendation. Hey, Emily, this is what I think we should do. I'm not sure if it'll work. What do you think? I'm open to input, or feel free to disagree with me if you don't agree with me. As we're having this conversation with the, whoever it is, giving them the ability to feel safe, to open up and to know that we're on the same team, I think is helpful. And, okay, we need to fix this issue. How do you think we should fix it? These are what the issues are. How can I help you to do that? Is there anything you need me to do to help? And a lot of times there might not be anything that you can do or that I can do personally, but for them to know that I'm willing, is there something else I can take from you so that you can help me with this other thing? It's all about collaboration and recognizing the human aspect too, because at the end of the day, we're humans and there's more to us than the job that we do at work.
Well, even what you said before, Brandy, like once a therapist, always a therapist. At its foundation, we've been taught to be able to have influence when we don't really have influence over our patients. We physically cannot make someone do a bicep curl
Yeah.
or a leg press, but we can motivate them in the right way to do that on their own. So I think at like that very foundational level, we've been able to translate that, and you're a walking example of how that can be applied to a bigger role into like larger groups and in different positions. So it's really cool to see.
Yeah, we're advocates too, right? Because we advocate for our patients, but we also advocate as a quality director, we advocate for our team. If there's something that we need to do because someone else, some regulatory body or, some manager, director, CEO is saying this important, but your clinical teams are struggling, then you can speak to that. You can say, I know this might be difficult at this time for this reason. Or let's see if I have an example of that. I was having a conversation with someone about dialysis. As a therapist, patients do better if they do their therapy session before dialysis, as opposed to when dialysis is over, because they're just so fatigued. The treatment is a lot for the patient to undergo. So we were just talking about dialysis scheduling and how do we schedule that so that they can get their therapy, because we're a rehab hospital. We want, the focus is therapy. And so as a therapist, I'm thinking, how can we push dialysis to the afternoon so that all their therapy can be in the morning? How do we get 3 hours of therapy in the morning or between morning and early afternoon so that once the patient finishes dialysis, they can go back to their room and rest or eat or whatever they need to do. Even if we started dialysis at 8 in the morning and got done at 12 and we have from 12 to whatever time to do therapy, still 4 hours later, the patient's not going to want to do therapy after dialysis. So you're always thinking, how is this from the clinical side of, from a business perspective, let's just schedule it whenever. But from a therapy side, how do we remember that the impact that this treatment is going to have on the patient?
That's such a good example. And I think that's something everyone who's done inpatient has experienced. And that's something so simple too, that not simple, but something that's maybe tangible that all of us have experienced. And it's a great way that you can start thinking about how you can make a difference, being able to step into new responsibilities in your role. So
yeah, and being able to speak to that. So for those who want to transition to a quality director, if you've ever worked in an acute hospital and you're able to talk about dialysis, there you go. That was free.
I love it.
It's kind of a backtrack, but there was a quick comment about how your role is typically reserved for RNs. I don't know if you know anything. In my experience at my hospital, it was union-based, so there was literally no possibility for anyone but an RN. So I don't know if you know if it's by state or if it's unionized or how many other people like you who aren't RNs.
So I think it's based on the company itself and the company seeing value with someone other than a nurse. I mean, there are more companies than just the one I work with that will put a therapist in that position, or not even a therapist, not even from a physical therapist, occupational therapist, speech therapist, but respiratory therapist, or even a business person in that quality role, or a case manager in that quality role. So I think it just depends on the company. I live in the Southeast. So there aren't really unions down here. We don't have a lot of unionized. I can't think of one union down here in the Southeast. The thought is that the nurse knows all the medical side of being able to get into the record and to be able to have that peer-to-peer conversation with another nurse to say, why is this not working when you're talking about invasive procedures and operating room and dialysis? But, as a therapist, we can too. We just have to be able to show that value. I've worked places before where regardless of how much skill I had, I wouldn't have been able to move into a role at this level without a registered nurse behind my name. But there's other companies where they want a therapist.
Well, that's good to know.
Yeah.
Thank you.
For this role, was this the one you worked with the recruiter for, Brandy?
Mm-hmm.
Were they steadfast on the RN position? And like, how did you show your worth as a PT?
So my current employer really values the therapist in roles like these. So it wasn't a hard sell from a therapist perspective. It was more of, do I have the skills to do the job? Not, am I a therapist or a nurse? Where I had to show value was the fact that before this role, I hadn't managed people from I managed students, but I hadn't managed people in this way before this role, right? So that was new. I hadn't done medical staff credentialing before. But again, we don't have to check every box. We can learn as we go too. So it's been definitely a learning process. This role was more of, can you show us how your skills transfer? The things that you did before, how does it transfer to this role? Yeah. And so that was the sell more so than my clinical license.
Yet another reason to follow Brandy on LinkedIn, because if she's posting a role, it's from a company that celebrates therapists and non-traditional roles, and that could be an avenue.
Absolutely.
Not specifically Brandy, but any company.
Job.
Yeah, you can be one connection, because I posted, this was a while back, a couple months ago, several positions at my current employer that are open to therapists. I mean, there's some people who want to be CEO. We have CEOs who are speech therapists and physical therapists, and
love it.
So, I mean, it's wide open.
If they're listening, come on our podcast.
Yes.
I want to get to your show and tell, Brandy. So we have Brandy's top 5 tips for transitioning into a non-traditional role. Let's hear them.
Yes. Okay. Number 1, and these are in no particular order, by the way. Number 1, find a problem in your current clinical role and solve it. So I mentioned this a little bit earlier, but if your leader asks for volunteers for a project, take it, because the goal is to gain increased transferable skills. You don't have to have a formal title. I think people want a title before they start doing things. They want to actually get quote unquote paid. But at this point, you're just trying to add skills in your tool belt. I mean, you might find something you like or a way to contribute, and you'll meet people who may think of you when a role that fits your skill set become available. So if you can find a problem in your current role and solve it. I talked about some of the examples from myself personally, being a clinical instructor, EMR super. Yeah, there you go. A super user for your electronic medical record, being part of some sort of project lead for, in my case, it was an orthopedic pain management group, but it could be anything, right? All right, so that's number 1. Find a problem in your current clinical role and solve it. Number 2, shadow. So you find people who are doing what you may want to do and ask them to shadow them at work or remotely. This is one of those non-intimidating ways of connecting with someone. Is you don't have to always get paid for there to be value. If you can shadow, see if you like it before you just randomly apply and figure out that you don't like it. All right, number 3 is look outside of your work. So you can have transferable skills from other things you do. I've been secretary on my homeowners association. You could do something, if you're doing something at your church or community group, when you're applying for jobs or trying to transition, those are valuable skills as well. It doesn't have to be work related or clinically related for it to be transferable. Number 4 is upskill. So online courses, certifications, joining professional organizations. When you upskill, you want to be sure that you can actually use those skills versus having some certificate just to say you had some certificate, because certifications mean very little if you haven't actually put them to use. And I find that employers, hiring managers will ask you about them. And if you can't speak to them or how you use them, then they're going to question other things that you've put on your resume that may sound like fluff. And then number 5, be selective. So don't apply for every job that's out there. Tailor your resume to the specific role that you are applying for and how you can contribute. It's not just about what the company can do for you, but what you can do for them. I'll see resumes of people and their objective statement is how they want the employer to give them a chance and do all these things, but really that you have to be able to show value unless you're volunteering. That's an option too, to volunteer. So that's bonus number 6 is
Number 6.
Volunteer, at an organization that you really want to work for, and show your value, and then apply for a job, because then they'll know you. So top 5 tips plus bonus 1.
I love those. Those are great. Those are great tips.
Thank you. Yeah. I mean, and I've seen it in my current role too. You see someone who wants to transition to something that's non-clinical, it just seems like they're throwing darts at a board to try to land a job. And no employer wants to feel like that. They want somebody who's going to be able to add value to what they're doing and their mission.
Do you have experience, Brandy, as a hiring manager reviewing resumes?
I do. Yep.
Any pointers there, or any big takeaways?
Yeah, so it goes back to some of these. It's raising your hand. I've seen several resumes and done interviews with candidates who made that, we talked about at the beginning, but made this switch in their head. They want to do something non-clinical and has never volunteered for anything or done anything non-clinical at their current role. And so, as an employer, you think, what's causing you to make this switch? And have you really identified what's going to be of value?
Have you done your due diligence? Have you researched it?
Exactly. Exactly. So that's one thing I see. And, not just have a certification to have a certification, to be able to speak to it and to be able to say how you use it. And you have to make it easy for the employer to choose you. If the employer, especially if the employer is not a clinical background, you have to spell it out for them. You can't expect for them to connect the dots to say how this is going to translate. And I have a clinical background, so I try to connect the dots for people in my own head, to connect the dots when I see, maybe they're thinking this, but really you have to spell it out. Yes, which is why you want to be selective, because you don't have time to do that for 100 different jobs.
Kind of as I alluded to earlier, Brandy, you were really one of my first kind of contacts into this non-traditional world. So thank you for everything you do for the community. You're always so giving to us. Is there anything any of us can do in return for you?
Well, thank you for those kind words. And I appreciate the work that you all are doing. I am honored that I was one of your first connections. I did not know that till this call. But I'm super impressed with the work that you all are doing with the clinician transition and with this podcast. I was telling Julia, man, I wish I would have thought about this first. I mean, this is such a great idea to have this platform to share with those who are wanting to transition, because it could be very daunting. I applaud the work that you do, and, the platform that you have and the people that you're reaching, I think is so great for the profession. Because when I started out this path, this didn't exist. All of these resources that are available now did not exist. So it was kind of figuring it out on my own. And if I had known, if you all were there when I first started, man, I would be way down the road. So I appreciate the work that you all do too.
Thank you. Awesome.
Well, people like you paved the way for us. So thank you.
Yes. Yeah, well, thank you. It's super cool though to see how it's coming around now, and how so many people. I mean, you're thinking about new grads are transitioning early. They're like, wait, I've done all this work, and this is not what I want to do.
Like, no, you have to suffer before you get here. No, that's not what we want. We want people to know it.
Well, I wonder what the schools are going to say, honestly, when they're training these therapists. And you know how schools keep up with who's getting jobs when they first graduate, and when they find out. But when they find out that people are not working clinically, what are they going to think?
I thought about that too, not to get too much into a tangent, but I wonder if on the flip side of that, it would be a good thing, because it would broaden the jobs that you could get out of PT school, and maybe even the salary ranges that people could have out of PT school and the growth potential. Mm-hmm. But I don't know. Yeah, it could go either way.
I think we might have to have Brandy back on for a second episode next season to talk about all this stuff.
Yes. Yes, round 2, part 2.
Yeah. So stay tuned.
Yeah, because who knows what's who knows what's in the future, right?
Thanks to everyone for listening to this episode of the Beyond These Clinic Walls podcast. As always, be sure to follow us on LinkedIn and Instagram at Beyond These Clinic Walls for all the latest updates and episode releases. Make sure to join the Clinician Transition Group on LinkedIn and Slack to be part of the networking community for like-minded rehab professionals. Questions, comments, concerns, or do you know someone who might make an excellent guest on our next show? Reach out to us at beyondtheseclinicwalls@gmail.com. And as always, thanks so much for listening.